People may ask, why do we take such a comprehensive, patient-centered approach? Because every patient deserves more than just a patch. They deserve a chance to recover.
Hello, everyone. Well, I've said it once before and I'll say it again. It has never been a better time to have chronic pain. What do I mean by that? Well, we live in a time where technology has advanced beyond what I can even imagine even 20 years ago, 30 years ago. The things that we're able to do now is just amazing. One of those reasons is something called the spinal cord stimulator. And while there are many companies that are biting at the bit to sell you their product, I had to convince Wayne to come on here in order to tell us a little bit about his, because I think his is the best, even though I could make more money with the competition. But Wayne, thank you for being here.
Yeah.
And tell us a little bit about yourself and how long have you been with Boston?
Yeah, so been with Wayne McLaws, been with Boston Scientific for almost 8 years now. And at the risk of sounding cheesy, I have to pinch myself still. It really is amazing to be able to make the kind of difference we make in patients' lives every day. And got 4 kids, 2 of them adults, 2 still at home. Married to my sweetheart for 22 years, and it's got the good life.
Very good.
Yeah.
And so, so everybody understands, you are a representative for
Correct.
Boston Scientific. Obviously, they have many different medical products on the market, the spinal cord stimulator being one of them.
Yeah, exactly. So it's kind of an interesting job because I've got multiple customers. The patient is my most important customer. Of course, yourself as the provider is a customer, and then the facilities are customers. So lots of people to keep happy. But ultimately, if the patient's happy, everyone's happy.
So when the topic of spinal cord stimulators comes up with my patients, I'm not going to lie, the idea is a bit turning off from them. They think spinal cord injury, they think needles in the spine, that can't be good. And they immediately go, no, I don't want to do anything from, that crazy. I'll go have surgery instead.
Yeah, exactly.
Yeah.
They should be nervous, right? When you first hear anything that has the word spinal cord in it is scary, right? Because you watch the news and you see horror stories. But really, most patients are familiar with an epidural injection, especially those that are mothers that have gotten that procedure done. And really, the risk is very similar. You can correct me if you think I'm off there, but basically, as far as the way the needles are placed, there's really not a ton of risk. I'm not going to say no risk, but there's really not a ton of risk to the spinal cord at all. So we can get into what exactly is going on there, but there's not a ton of risk.
It is a very small risk overall. I mean, even single digits,
right?
Depending on the complication you're talking about.
Yeah.
I've done countless of these procedures by this point, and I've only ever seen one complication. So this was can I tell the story?
Mm-hmm.
I know we're kind of early into this, but people ask, and they're like, well, what would happen? What's the worst case scenario? Well, I'll tell you.
Yeah.
We were in the hospital, and this was when I was an intern. And so I'm following the neurosurgeon resident, and then of course there's a neurosurgeon attending who's not in the room. And so this patient comes in, we're doing a placement of the stimulator. And so the back is dissected down to the ligament, maybe that big of an incision. And the chief resident is doing it, and I'm just watching because I'm an intern. Well, anyway, he's struggling to kind of get it in the right spot, and he's getting a bit rushed and starting to feel a bit frustrated, but he's not being very aggressive with the procedure because he doesn't feel like he needs to be. Well, eventually the attending comes in. What's taking you guys so long? Let's get this process going. So he takes over, really starts jamming the needle in, trying to get it in and hurry the process along. Well, he does. He gets it in and everything's great. And okay, patient goes to recovery, wakes up, can't move their left foot drop. Oh no, that can't be good. Now, in that case, right, we're all kind of sweating. I know,
Sure.
I'm like, oh, this is crazy. I've never seen this happen. Send him off to MRI. Sure enough, there's a hematoma that's developed, which is a collection of blood right over the nerve. And because he's a neurosurgeon and we're in a hospital, brought him back, did surgery, patient did fine. Like no permanent damage. But that can happen. But even still, that was a unique case because the patient had undiagnosed von Willebrand factor syndrome, which basically meant they were more likely to bleed. But we didn't know that going in. So, but since then, no, I've never seen something like that happen. Not to say it couldn't happen. That particular case, I'm sure I think it got written up as part of a publication.
Well, there's
Because
a
of
lot
how
of
rare it
safeguards,
is,
right? Because it's not like you as a physician are going in blind, right? The whole
No.
procedure is done under fluoroscopy, so we know where the needles are. You're tracking that as you're advancing the needle. So, anyway, yeah, really not a whole lot. Like I said, not a whole lot different than a epidural injection. It's just that instead of medicine, we're feeding wires up, which we'll get to. But yeah.
Yeah, no, that's exactly right. So whether you're a laboring mother who gets an epidural blindly, right, without the use of
Yeah.
fluoroscopy or X-ray guidance, right, plus you're in labor and kicking and screaming, and you have the anesthesiologist down there right in the bowl trying to get that in the right spot.
Yeah.
They do fine.
Yeah.
Probably the most common pain procedure performed in the United States is the epidural steroid injection. Been around forever. Like you said, in this case, we're just injecting a needle, or we're injecting a wire rather than injecting steroid.
Mm-hmm.
Yeah.
Yeah.
So, what are some of the cool stories that you've seen as far as patients getting better from this type of thing?
So, we have even just since I've been in the industry, we've come so far technology wise. It used to be, and we'll get into, the trial and all that, but it used to be that we would put one of these systems in and they would have to wait days before they got any kind of relief. There was what was called a wash-in period. And I won't bore everyone with too much of the weeds and as far as the technology goes, but now we have therapy that is pretty much immediate relief. So the patient goes home from the office or the hospital already having great relief. So that's really cool to see. And even while we're programming, there's a condition. We'll get into the different conditions or indications for this therapy, but there's one called CRPS, which is really an egregious. I mean, it's takes people's lives away from them, quality of life, that is. And that usually comes, after a surgery or an accident of some kind. And usually it's kind of focal pain, like in the hand or the foot or something like that. And we treat that, that indication. And I had one lady, as soon as I turned this, I was brand new rep. I'd probably been doing this for maybe 2 weeks. And as soon as I turned the therapy on, she started bawling and I got scared to death. I'm like, what did I do? What did I do? And I said, what's the matter? She says, nothing. She says, I feel no pain. I haven't felt this way in, probably 15 years. And this is a condition where for this particular lady, she couldn't wear a sock. She couldn't have the sheet over her foot. She couldn't have the water in the shower hit her foot without just excruciating pain.
Yeah.
And she even bent over and was touching her foot and just amazed. We even saw some of the discoloring in her foot change actively as we're turning on the therapy. So those are experiences you really never forget. And I've seen that same thing play out over and over and over again at this point. But
so we're talking complex regional pain syndrome is an indication for this.
Right.
We're talking failed back surgery syndrome,
which is such an interesting. When I first started in this whole world, I thought there's a condition called failed back surgery syndrome.
I know the orthopedic surgeons love.
I'm
that.
sure they love that. Yeah, exactly. They probably will find something else to call it if they refer a patient over. But anyway, but that's actually the most common, right? Is these patients that have just been through hell, right? I mean, they've had a fusion in most cases, sometimes like a full 360. And it might fix one problem, but it introduces two others, right? And they end up having just persisting back pain, chronic back pain that is just that dull, achy, never go away type of pain in their back. So that's our most common patient. And then radiculopathy, the pain that kind of radiates down the legs as well.
Radiculopathy is a big word. Sciatica. Would be another way to call that.
Yeah.
Shooting pain down the legs.
Pain down the legs. Diabetic peripheral neuropathy is kind of a new one over the last year or two that we've gotten FDA clearance for. And so obviously those are, diabetic patients that have that numbing feeling in their feet usually that kind of evolved into more of a painful numbing feeling. Have great success with that as well.
Now, just to be clear, a lot of patients will have numbness. This won't bring back sensation.
Correct. I've had a few that have reported that, but
Yeah.
we certainly don't promise that. It's more just the pain associated with it that we can help with.
Right.
Yeah.
Going back to failed back surgery syndrome. So my theory on that is the longer you have pain in one particular part of your body, it's kind of like you lived your whole life with your foot, and then if someone chops your foot off, you still feel it, right? We
Right.
call that phantom pain.
We treat that too, by the way. Yeah.
That's true. That's another
Yeah.
indication.
Yeah.
Which is probably why it works for failed back, because I think of it in the same process. The longer you have pain, you get these patterns in your brain that just, this is how it is now. And those electrical signals just keep going round and round and round, spinal cord to brain, spinal cord to
Yep.
brain. Even if the surgery fixed the problem, the pain persists.
Yeah. I always tell patients, you don't feel pain until your brain finds out about it. Right. And so
Right.
if there's a problem area in the low back or the legs or wherever, there's a pain signal that goes up, through the spinal cord and tells your brain that, there's a problem here. And so the job here of the stimulator is to block that signal.
I wish I could do more diabetic patients because I feel like that's such a great treatment for them. Most of the time they're coming into the clinic on gobs of gabapentin, gobs of Lyrica. They can't remember half the day because of the medication. It causes swelling in the legs and the feet, right? All this water retention. And it seems like with just one simple procedure, we could eliminate the need for those medicines.
Right. Yeah.
The problem I'm facing, at least in my patient population, is the need to get their hemoglobin A1C down.
Yeah.
Because there's so many that it's too high and that causes too much of a risk with the procedure.
Sure.
Yeah. But so that's great. Let's see. So we got failed back, diabetic neuropathy, causalgia or complex regional pain syndrome, sciatica. What else am I missing?
You said the DPN, right?
DPN, diabetic peripheral polyneuropathy.
I think those are the big ones.
Yeah. So how does someone qualify for this? Because I know, at least historically, it's been kind of the end of the line treatment for many patients. You have to do physical therapy, you have to do medications, you have to do all these other injections and procedures before someone will say, okay, fine, you can do the stimulator. And then they do the stimulator like, oh, I wish I did this 10 years ago.
Yeah, exactly. Yeah. Well, there's several factors in play there. One is obviously, the provider needs to make sure that they're a good candidate, with their clinical expertise. Insurance, right? There's different insurances want to see different things. But the standard across the board is usually at least 6 months of what they call conservative therapy. So that's going to come in the form of, meds, physical therapy, and those types of things.
Jose, does physical therapy work for diabetic peripheral polyneuropathy?
Not that I know of.
Yeah, I would agree with that.
Yeah, I've never had a case where that worked.
I mean, you can improve circulation.
Standalone therapy, no. Yeah.
Yeah, no.
Yeah.
Maybe by improving their circulation, but the nerve damage is still there.
Yeah. Once the nerve is gone, it's gone.
Right.
Yeah, that never comes back.
Yeah. The other thing that they like to see a lot of the insurance is a surgical consult where they've been ruled out for whatever reason for surgery or, they're not a candidate. Obviously being heavily biased, admittedly, I would love to see our therapy move up in the continuum a little bit. I think that there's a lot of patients that just maybe, they're 75, 80 years old. They don't really want or need to be, going into surgery. And this is something that can give them quality of life. But nonetheless, unfortunately, we still have to check some boxes for our payers.
So let's say you work your way through, you have one of these conditions, you work your way through a course of conservative treatment. Mm-hmm. What comes next? I guess it would be a trial.
Correct. So that's one of my favorite parts of what we have to offer. I don't know how many surgeries or treatments are out there that you can try it before you actually do it. Sounds kind of funny, right? But so our patients are able to try the spinal cord stimulator for about a week, go home, live their life without any incisions, without putting anything in permanently.
Right.
And so what that looks like, as you know, Dr. Leak would bring you into the hospital or surgery center, and there's 2 needle pokes, like we talked about, similar to an epidural injection.
No
and
cutting,
no cutting,
no
no
sutures.
incisions, all outpatient.
You can have sedation, but you don't even need it.
Correct. A lot. We have it done with
Yeah.
local anesthesia pretty often.
Mm-hmm.
So the needles are placed, and then Dr. Leak would feed. We call them leads, wires. It's kind of like driving a kind of a firm spaghetti noodle up into the epidural space. So it's really just hovering above the spinal cord. And usually kind of we land somewhere, around T7 in the thoracic spine. And it's kind of counterintuitive because you think, like, for example, let's say a patient had leg pain. You might think, well, why are we putting leads in the back? The spinal cord is kind of like the highway of nerves from the feet, the legs, all the way up. And so those nerves that we're stimulating in the back, they might be assigned to, even lower in the back in the lumbar region or in the legs or feet. And so, that procedure, the trial procedure, takes maybe 30 minutes. And then we go back into the post-op area and we program it. Programming sometimes takes longer than the procedure itself. We turn on kind of like a tingling sensation. We call it paresthesia. And what we're doing there is we're really just using that for mapping purposes. So there's a lot of, where do you feel it now? Where do you feel it now? And we're trying to get it just positioned so that we call overlap, right? We're overlapping where the pain is. It doesn't have to be perfectly exact. If we can't, get it exactly, where the pain is, there's still a really good chance for great relief. And then we send them home. And like I said, we say, go live your life, and we want you walking. If normally you can just get to the mailbox and back, try going around the block. Go walk around Costco for an hour and see how you feel.
Right.
So
Pay attention to how much medicine you're needing to take.
Correct.
You know, like you said, how long you can walk, that maybe longer than before.
Mm-hmm.
Maybe you're sleeping better than you were before.
Yeah.
Your mood is better. There's all kinds of measurements rather than just saying, oh, my pain came from a 10 to a 5 or 10 to an 8. Well, but look at all the things you can do now. I mean, that's pretty
Correct.
life-changing.
Yeah. Activities of daily living is key, right?
Yeah.
Our whole goal is to give you your life back.
Absolutely.
We want you playing with your grandkids or your kids and being able to do all the things that you love to do. There are some restrictions during the trial. We want to make sure those leads don't move. We're going to program them based on where they are right now. So if they move significantly, sometimes that can affect the outcomes a little bit. But that being said, we don't want you laying in bed the whole trial either. We want you up and around and testing it out. So we got to kind of find a happy medium there. But I don't remember the last failed trial you had, if we've had one.
I had one.
We did have one?
I had one. But that's because it was poor patient selection. I knew going into it, he wouldn't be a good candidate.
Yeah.
And in that particular case, it was his weight. Because I felt like it was more of a obesity-related issue. His muscles were straining, and he had this back pain. But he kind of tried everything else by that point and really wanted to do the stimulator.
Yeah.
So we did the trial, and unfortunately for him, it didn't work. But for the cases that I knew would be good cases, which I think is half the battle, no, they all went to permanent placement, and we're very happy to do so.
Yeah. 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 I mean, we're pretty close to 90% success rate. And we define success by anything better than 50% relief. Like you were saying, I like to focus more on we're able to do more, because the pain score can be kind of nebulous, right? I like to just ask questions like you were saying. We're able to be up and around. We're able to stand at the sink longer than you normally are. Could you go, instead of 2 pills or 4 pills a day, could you go down to 2 or whatever? Again, insurance likes to see numbers. So we're going to nail you down to give us a number on the pain score. But anyway, 50% or better. And it used to be 50% was pretty good. To be honest with you, I'm kind of disappointed now with 50% relief.
That's true.
Because we're seeing 80, 90.
Yes.
I never like to promise 100, but we see it happen.
Yeah.
And so, it's just been a game changer for so many patients.
So they come back. Let's say we do the procedure on a Monday.
Yeah.
You show up on a Friday back in clinic, see how you did. Of course, we're in touch with you throughout the week.
Correct. Yeah.
Right.
Your rep is going to talk to you. The same rep that programmed it is going to be calling you every day.
At least at Boston.
That's the way we work. We don't want to wait until the end of the trial and find out,
Right.
because sometimes we need to make some adjustments. Occasionally, rarely, but occasionally we'll meet halfway through and just make some tweaks. The thing that's important to remember about this is that we're stimulating nerves that are the size of a human hair. So if the leads move, that's why we're so focused on the bending, lifting, twisting stuff, the restrictions, because if the leads move slightly, we can fix that. We can program, but it does require meeting up to do that. We'll get to the permanent one in a minute. But yeah, so we meet back at the office in roughly a week. The leads come out a lot easier than they go in.
Mm-hmm.
That doesn't require any kind of sedation or
Yeah, you just
anything.
pull them out.
You just pull them out.
The patient doesn't even know.
Pretty painless, yeah.
Yeah.
You and I don't feel a thing.
No, I don't know. Not a thing.
No, but it really is pretty painless for the patient. There's really not much to that. You can drive yourself to and from. And then we just work on getting it scheduled. Usually, sometimes you're at the mercy of insurance for that because we have to submit for approval they don't just approve both of them. I wish they would, but you got to do the trial and then you got to go back and submit, for the approval from insurance. And then obviously, the doctor's schedule as well. So,
Well, I got a couple questions since he's brought up a couple points.
yeah.
So when you insert the leads and you said, you're stimulating hair-like nerve fibers,
Yeah.
how does the lead stay? Is it floating in the dural space? Is it attached to something? Is it anchored? How does it stay in there?
Great question. Yes to all those questions. So basically, especially for the trial, they are kind of floating in there, but it's a pretty tight space.
Mm-hmm.
The tails of the leads
Mm-hmm.
come out of the body, right?
Yeah.
Again, there's no incisions for the trial, and they're just taped down to the back.
Okay.
And then they're plugged into a device that they'll wear on their hip in a belt. So very rarely do we have a trial where the leads don't move some. It's pretty normal.
Okay.
But we're just hoping that by the time that happens, we've had a good sample of, maybe 2 or 3 days at least where they got really great results.
Mm-hmm.
But so for the trial, they are kind of floating in there a little bit, but we try and tape them down as best we can.
Okay. And for the trial, do they, like you mentioned, go ahead and go about your life? But you still have to be careful. You have to be careful with certain movements.
Absolutely. The rule of thumb that I like to give patients is if your shirt's tucked in, don't do anything that would cause it to come untucked. So
Okay.
that's kind of like the rule of thumb as far as bending over to pick something off the
Lift
ground.
with your knees.
Yeah, bend your knees. Don't reach really high for a coffee mug. Ask for someone to help you. It's not the end of the world if the leads move a little bit in the trial because it's a trial. The leads are coming out anyway.
Mm-hmm.
We just want to give ourselves enough time to make sure that the patient's a responder for the therapy.
Okay.
How many electrodes on each lead did we start off with? Do you recall going back?
Well,
Way in the day.
I don't recall because I think I was like 3 years old when this first came about.
Well, it's been around for a while.
It's been around for a long time, but I do know that
I'm not going to tell you when it came out because I would date you now.
I do know that they started with one. So just to give everyone an idea, you have the lead, but then on the lead you have these electrodes that provide the energy, right? So the stimulation. They started with one electrode. So what they would have to do is they would test live in the operating room and they would turn it on and they would say, "Where do you feel it now?" And they'd say, "In my right knee." And they'd say, they move it a little bit and they say, "Okay, where do you feel it now?" Okay, now it's in my right thigh. And then they would have to adjust it over to get right and left. And anyway, so this would go back and forth, back and forth. And back then, the machine or the computer, both for the trial and the implant, was external. And so they would have to wear something like on the outside forever. And then if that one electrode moved, they were back in surgery, right? So anyway,
Not to mention the infection risk and the
Right.
interference with your ability to bathe and everything. It's
Yeah.
Yeah. But just to give you an idea how far we've come, several years later, most of the companies came out with 16, we call them contacts, electrodes, 16 contact systems. So it went from one. I'm sure that there was some pit stops, maybe, with 4 or 8 or whatever. But for the longest time, 16 was the total amount because you're at the mercy of what the generator will accommodate, right? And so
the generator being the battery.
the battery.
that powers it.
Yeah, we use all these interchangeably. You'll hear IPG, which is a internal pulse generator. You'll hear battery. Even sometimes the can. Sometimes we'll call it. But anyway, so that really was a game changer because now we had went from 1 to 16. So in that case, it was a lot easier to get coverage of the painful area. And if the leads moved ever so slightly, it wasn't the end of the world. And then obviously we went from the external unit to now for the permanent one, everything's under the skin. Well, Boston Scientific, about 10 years ago, roughly, came out with a 32 contact. So we literally doubled up our competition. And so now what's beautiful about that is sometimes we have patients that have multiple pain patterns or evolving pain patterns, right? And so they might have low back pain for, failed back surgery syndrome, but they may also have neuropathy in their feet. And so how do you cover that much real estate? And so we're able to do that with our 32 contact system. So in that case, we take 2 leads that each lead has 16 contacts on them, and that's what Dr. Leak uses. And then the other thing that's nice about that is if the leads move ever so slightly, not the end of the world because we're covering 3 vertebral levels. So
and if you need to focus that power anymore, you can just on your computer and then
correct,
digitally correct for the lead migration. Before this was a thing, lead migration used to be like the primary reason for treatment failure, right? Because, I mean, like you're saying, you have 2 wires floating in the epidural space. And if you're an active individual, one of those wires starts to come down, then next thing you know, you have uncovered pain.
Yep.
And so now, because we have 16 contacts on each wire, you can move quite a distance and still reroute that power to other contacts and still get that same coverage that you had before.
Yeah.
So that's almost a rare cause for failure at this point. I mean, especially with these leads, I would think.
Yeah. So what our competition did to try to combat that is they started spreading out their contacts, right? So they still only had 16 total, but they were spreading them out to cover more area. Well, again, we talk about the size of these nerve fibers we're trying to treat. It doesn't take much to jump over them, right? As you're moving the therapy up and down, left and right, to try and capture where you need to capture. So it was a nice try by them, but it didn't really work. Yeah.
No, we're talking about very fine nerve fibers, very fine distance. I mean, centimeters can make a difference.
Oh, absolutely.
Millimeters can make a difference. So, but what's cool about your leads too is you can actually control the power between the contacts.
Correct.
Which is also, I think, unique to your company.
Yeah, it's a technology that it's called multiple independent current control. Very fancy way of saying each of the electrodes has its own power source.
Okay.
So I like to explain it like, we have some bright lights going on in here. The competition might be able to adjust it so it's half as bright and then turn the lights off completely. Whereas we're able to use a dimmer switch, right, with our therapy. And so we're able to fractionalize, the movement of the current by 1%, whereas our competition is, quadruple that with so basically, if you think about it like this, we have what's called a central point of stimulation. Okay, so we're stimulating the current on these leads and we're moving it around to try to capture, where their pain is. and from a programming standpoint, it's almost like a video game. We got almost like a joystick where we're saying, oh, you feel it too low? Okay, tap, 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 tap. We'll move it up and we'll move it left and move it right. And we're just making much smaller jumps so that we're not, skipping over the nerves that we might need to be treating.
Yeah, absolutely.
So if let's say my mother has pain and we've been investigating different types of treatments, what is my first step? Seek out a pain clinic, pain doctor? What would be my first step?
Yeah, the first step would be consultation with interventional pain specialist. I recommend Dr. Leak, but there's others out there
I paid
too.
him to say that.
Yeah, me too.
But anyway,
No, I didn't pay him. Sorry.
yeah, he did not pay. But the thing is we got to first identify what's the pain generator, what's causing the pain. Because if it's a mechanical pain, bone on bone situation, arthritis, those types of things, I'll be the first to tell you this is not going to work for every patient, right? And so and I'm not even qualified certainly as a rep to say where that pain generator is coming from, but certainly by looking at imaging and doing an in-office evaluation, the pain management provider can.
That's the goal.
Can determine
find where the pain is.
Find where the pain is and what's causing it. So that would be the first step. Yeah.
Okay.
So we talked about the different technology with the leads and the risk of migration. I know we touched on maybe risk of infection. The longer you lead the leads in, at least during the trial period, there's an increased risk of infections. That's why we stick to 5 days.
Yeah.
So they come back, they said, hey, you know what? This works really well for me. Then we go ahead and get them scheduled for the permanent.
Yeah, and ultimately, this is never a bait and switch type of situation, right? Where you have really great results in the trial, and then we go do the implant. I know there's always concern around that, right? What if I do the implant and I don't get the same results? The technology is identical; it's the same exact thing, right? We're putting leads that are pretty much just identical to the trial leads that we put in, and we're using the same generator. It's just that this one's under the skin. And then we program it. So again, outpatient procedure. There's 2 incisions, maybe about that big. Dr. Leaks are even tinier than that.
I like to really stuff it in there.
Sometimes I'm like, if you just made that incision a little bigger, but the patient's thankful afterwards.
Yeah.
The
battery's not that big. I mean, it's only like.
I like to say it's about the size of an Oreo cookie.
Yeah.
Perfect. Yeah. So, same thing. This time there does need to be an incision because we have to put everything under the skin. But same thing, kind of like an epidural injection. The needles are placed, feed the leads up into the right spot in the spine. And then we tunnel the tails of the leads under the skin, kind of into the flank area where we all have a little extra meat down there. And that's usually where we'll put the battery or the computer or generator or what have you.
The battery eventually runs out.
It does.
Can't stay there forever.
It does. There's a couple options with regard to that. There's a rechargeable option and there's a recharge-free option. There's pros and cons to both. A rechargeable obviously needs to be recharged. And so, but we've gotten so efficient, maybe we can talk about the programming a little bit too, but we've gotten so efficient that it used to be that patients would have to charge every day, sometimes multiple times in a day. And now our average patient is charging once every 2 weeks, some even once a month. And so there's that piece. And then there's the recharge free option where you don't have to worry about it. So the pros and cons are this: rechargeable lasts 7 to 10 years, but you do have to charge it periodically.
How often?
You charge it maybe once every 2 to 4 weeks, I'd say.
How long does each charge take? A couple hours?
A couple hours, yeah.
That's not that bad.
It's not bad.
Like every 3 to 4 days or something.
It's really not bad.
No.
And then a recharge free. That stimulator is a little bit bigger, and so that would might be a little bit of a con, a little bit bigger, but you don't have to worry about it, right? You just put it in, forget it, and that lasts about 4 years. The other one lasts 7 to 10 years.
So maybe because you can tell during the trial period, perhaps how much power they're drawing off the battery.
Yeah,
And if it's just a little, you might go with the non-rechargeable.
You might, yeah, and we may even get up to 5 years or so if that's the case. And then there's obviously other things too, right? I mean, if they, patient lives alone, not super tech savvy, not that you need to be to charge it. I mean, it's just a device that looks like a hockey puck that you just charge through the skin. But anyway, there's some patients that just say, look, I don't want to have to deal with it. And so that's perfectly fine. There's no right or wrong answer to that. It's just whatever the patient prefers.
So once everything's inserted, whichever type, how often do you check with the patients? Do you check with the patients? Does the doctor check with the patients? Who follows this up?
So they'll have their initial post-op appointment, usually
10 days,
yeah,
14
10
days.
days or so afterwards. We'll be here for that.
Mm-hmm.
I always tell patients, we're here for you. We've got hundreds of patients. You have one person to call. So if you need us at your appointment with Dr. Leak, we'll absolutely be here. That's no problem, but we don't know about it unless you tell us.
Mm-hmm.
So if we don't hear from the patient, we'll check in over the first couple weeks.
Mm-hmm.
But then after that, it's kind of one of those things where it's like, if we don't hear from you, we assume you're doing really well.
Okay.
That's for the permanent one. For the trial one, we're talking every day because it's new
Yeah.
and we have a shorter time frame to work with.
So once you get it inserted and you go through the first period of checkups, and you're pretty much on your own unless something goes wrong.
And sometimes there is something called habituation, which I'm sure you're obviously both familiar with, but for the patients out there, habituation is kind of where your brain figures it out, right? And so there's some countermeasures to that from a programming standpoint, the technology that we have now, where we can program it so that it's on a schedule. So it'll run one type of therapy for a few hours and it'll switch to another one. And that kind of keeps the habituation from happening. But still, for some patients, we do need to meet up. I would say the average patient, we probably meet them maybe twice a year for some adjustments. Yeah.
So the advancements in technology obviously has been profound in the last 5 to 10 years, especially when you compare that time period with the preceding 40 to 50 years.
Right.
This has just been a great time for the industry.
Yeah.
And the patients, quite frankly. In fact, I think we're even explanting a lot of older generation stimulators and putting in the new stuff, and it's making a world of difference for these patients. And you can imagine their apprehension. Oh, I don't want to do this again. It's already not working. But lo and behold, they're taken by surprise. So we talked about the actual physical advancements with regard to the lead, but there's also advancements, like you said, with the programming. And I think even some programs that are unique to Boston that can reduce the habituation, that can provide longer relief. And also this concept of you can feel it, but sometimes you can't feel it.
Correct.
Tell us more about that.
So a few years ago, and I'm a big believer in giving credit where it's due, there was another company that came out with what's called a subperception therapy. And so basically that was this idea that maybe we can run it at a high frequency, but where they don't feel it, and see if they can get relief. And it worked. Most patients did really well. So they were running at 10,000 hertz. So there's different ways that we measure the therapy. There's the amplitude, which is obviously the strength of the stimulation. And then there's the rate, which is we measure in hertz to say, okay, how fast is the stimulation going? So the idea was maybe we could run it at a higher frequency and a lower amplitude, and they could get, great relief and not have to feel that annoying. Some patients love it. Others find it really annoying to feel that tingle all the time. Some compare it to a TENS unit. It is a similar sensation. TENS unit, we're stimulating muscle. This, we're stimulating nerves. So the science is totally different. But anyway, so Boston Scientific said, great. Well, we're glad it worked. Let's see if we can make it even better, because some of the pain points around that new therapy was, one, it wasn't lasting. They'd get great initial results, but then over time it would stop working. I have some theories on that. I think that they were overwhelming the nerves with 10,000 hertz was just way too high. And then the charge burden, right? First of all, they still don't even have a non-rechargeable option with that company because they would be replacing it about every 6 months. So the charge burden was just through the roof. So these poor patients were having to charge every single day, sometimes multiple times a day. Anyway, so we started playing with it, and we did some studies, and we said, okay, let's just start lowering that rate and see how low we can get while still getting good outcomes. And now we're all the way down to 90 hertz. So you think we went from 10,000 hertz down to 90, and our patients are getting superior outcomes. The charge burden is next to nothing. And the other issue with that other therapy was that there was a wash-in period. So it would take 2 or 3 days for the patient to get relief. Well, think about that. You're only doing a 5 to 7 day trial, and 3 of those days you're waiting for relief. So now what we're doing is with this, it's called fast acting subperception therapy. See what we did there? So they're getting fast results, like immediate results, like within seconds. So they go home already super optimistic during the trial, and so it's just been a total game changer. It's called surround inhibition, is what this therapy is. It's what the mechanism of action is. The easiest way to describe it is if you were to poke your arm with a pin, the first thing that you would do is rub it, and that would almost immediately make the pain go away to a point where you wouldn't feel it anymore. And that's called surround inhibition. Basically, you're activating the nerves that surround the problem area. No one had ever done that or even tested that out in spinal cord stimulation. So that's the therapy. That's the mechanism of action that FAST programming offers our patients. And that, to me, when we came out with that, that's when we went from like the 50, 60% relief up to the 80s and 90s on a consistent basis.
Right, because now you're not even stimulating the nerves that are transmitting pain. You're stimulating the nerves around the nerves that are transmitting pain.
Right.
And basically overwhelming the brain's ability to sense all of that and make sense of it. And so your pain is gone.
Yeah, and we're running it at 30% of perception. What that means is when the patient can just barely feel the tingle, we call that 100%. We're running this at 30%.
Wow.
Yeah. So not only are we at 90 hertz down from 10,000, but we're also at 30% of perception. So you can imagine what that does for the battery life.
Well, and then how great for the patient, because it used to be that all you felt was a vibrating sensation in your back.
Right.
And now all they feel is no pain or less pain.
Relief. Yeah.
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 Amazing.
It's been awesome.
I don't know, Jose, it sounds like pretty good.
Yeah, that sounds very interesting.
I might go give me some back pain. Try it out.
Yeah.
You know, the other thing too is just we're not burning any bridges, right? So there's really, if we put one of these in and some miracle procedure comes down the road, which hopefully it does, we're not burning any bridges, right? We can still, this thing comes out, just easier than it goes in.
Mm-hmm.
And if you end up being a candidate for surgery or needing surgery or whatever, we're not doing anything structurally to the spine.
It's not a fusion.
Mm-hmm. It's not a fusion or nothing like that.
Right.
Yeah.
Well, and the reality is pain is still it's a mystery. It's still hard to work with, and everyone feels different. Everybody feels pain differently. Mm-hmm. And a lot of times, as much as we don't know what's actually going to work until we try some things. So, in my time here, just some of the patients that I've had and some of the chronic injuries or chronic pain that they have, I realize I scratch my head. I'm like, you need something else just to get you through the pain so we can get you moving. So I can see where this would be a real impactful therapy so that they can actually exercise.
Right.
And so be able to get back to moving, because if you don't move, you're never going to get through. Right. You're not going to get better. So
that's a really great point.
Yeah. I can see this being very interesting for people with pain, because most of what keeps people from exercising is the pain. Mm-hmm. And the idea of blocking pain, as long as there's no structural issues with exercise, if you block the pain, you can get moving and you might actually get better.
That brings up, I think, a good thing to talk about just briefly too is restrictions after the implant, right? So for the first just handful of weeks after the implant, you'll have the same restrictions that you had during the trial. After that period, the leads are kind of scarred into place. One of the rare situations where scar tissue is a good thing.
Mm-hmm.
And then after that, I mean, you can do anything. You can do yoga. Obviously, physical therapy would be the goal. And a lot of people, one of the criticisms might be, well, you're not really fixing anything, and that's true. That's true. This is, we're blocking the pain signal. The big but to that, for me though, is to your point. If we can get you more active and strengthen your core, right?
Mm-hmm.
I know that's music to your ears as a
Mm-hmm.
physical therapist. Then some of those problems might fix themselves, right? Because we're able to help with the pain so that you can do some of the things that'll make you stronger.
Well, I mean, the idea of physical therapy is how do you mitigate pain? How do you alleviate pain so that they can exercise?
Right.
And traditionally physical therapy, uses all kinds of modalities, has used all kinds of modalities to slow down the pain, to control the pain so that they can exercise.
Sure.
Because physical therapy, physical activity is not about completely eliminating pain, is controlling it so that you can do what you need to do. And I don't think anybody lives pain free. I mean,
Right.
No.
if you live,
Even if you're healthy. Yeah.
even if you're healthy, you're going to do something to cause yourself pain, and you do something about it, and then you continue doing whatever it is you need to do. And so that concept of blocking the pain so that you can exercise, I mean, to me, that's the key to an active lifestyle, because you're going to hurt no matter what you do. You go on vacation, you come back more sore than you were. And so with this device, if you can get people pain relief, they can exercise and they will be able to heal better. They might be able to do more things, and you never know. You might actually do it with some of that pain and might be able to get off of it.
Yeah.
Depending, obviously depending on the
Sure.
on the patient. But I have had many times when I have a patient and they tell me the story. They've had a lot of pain, and because of the pain, they quit doing things. And so as they quit doing things, things just get worse. But sometimes I can convince them, no, let's keep moving. And once they start exercising again, and they realize, you mean to tell me that I'm not going to get worse by exercising? Once that light goes off, they're like, okay, I can do things. They exercise, and they're like, hey, you know what? I can actually deal with this little bit of pain, and I'm back to doing whatever it is.
Yeah.
And I've had several of these right here, and where once I convinced them to let's exercise, and once they did, they're like, oh, wait a minute, the pain's not that bad, because now I have higher pain tolerance. I'm a little more fit. I'm creating blood flow. I'm all the things that you get from exercise. But if I can get a device where it blocks the pain and allows me to move, then maybe I get better.
It's awesome to be able to offer a therapy that gives them a new lease on life without the side effects of opioids.
Yeah.
Well, and that's exactly it. As a pain specialist, I don't like the idea of just masking pain, right? I like the idea of, let's figure out what's causing your pain and then solve that problem so that your pain gets better,
Mm-hmm.
right? But there are cases where you can't do that. I mean, you have like the phantom limb pain or the nerve pain that persists after surgery when you did everything that humanly that can be done, and you still have this issue that's life altering. So you're stuck with the management approach. But then you're looking at medications, which have all kinds of issues, or potentially a spinal cord stimulator, which can reduce all of those potential issues. That's a no-brainer.
Yeah.
Put that in. And
Yeah. I do have to give a little bit of a plug, even though, it's not in my lane necessarily completely, but just this idea of interventional pain doctors and all the tools that are in their belt. Spinal cord stimulator is just one of them.
it is one tool.
It is one tool,
It's
but
an
there
awesome
are
tool.
so many. It's mind blowing to me
Yeah.
how little they're known about.
Yeah.
How,
Oh, yeah.
I
It's
even talked
evolving so constantly.
I even talked to primary care docs that this is so foreign to them. They're used to just sending the surgery,
Right. Right.
And usually I think a lot of times when people think pain management, they just think meds. And that is like such a small part of what you do here. I just wish we could get more people to come and see all the tools that you have in your belt, because there's an answer for almost everything.
So 5 to 7 years is the average time someone waits with pain before they see a pain doctor.
Hmm.
And I think a big component of that is, well, I don't want to get hooked on drugs.
Right.
Right.
Yeah.
And I think, unfortunately for our field, that has been the case for so long.
Yeah.
We were writing more opioids, not me. I was in college, but back in 2010, 2011, more opioids per capita than, anywhere else in the world. That's come down a lot since then, thank goodness. Although the transition has been rough, I think, for a few patients. But
Well, and the irony too now is it's some of the other specialists or even primary care where they get stuck in some of those loops of just keeping them on these meds because they don't know of any other options.
Mhm.
correct.
When now, if they would just refer them to interventional pain, that's where they get off of that stuff, because there's so
Absolutely.
many more tools.
Absolutely. Yeah. And the longer you've been on it, the longer it might take to get off. But I'm thinking of one patient right now. She was on opioids for probably 20 years and for really bad spine pain.
The
And
one we just saw a few weeks ago. Yeah.
she had
Yeah.
surgery, she had injections up the wazoo. And yeah, 1 year ago now, we put her on, we did a spinal cord stimulator in the neck, and her pain was like gone. I mean, gone. And it took a year to get her off the pain medicine because she's been on it for 20 years, right? The brain changes.
Mhm.
But in that year period, we got her off and we discharged her from the clinic. She's feeling great. She doesn't need a pain doctor anymore. It's amazing.
Just showed up at your little open house or whatever that we had.
I was
here.
like, "Who are you? You look
Grand
like a totally
opening.
different person."
Yeah,
It's amazing.
She's like begging me to put her on as like an ambassador or something. I'm like, we should. Yeah, that's pretty cool.
Yeah. Well, that's excellent. So, one thing I want to address too, I think a lot of patients, they're like, isn't this like the same thing as a TENS unit, right? I think you mentioned that earlier.
Yeah.
TENS unit, it's a little bit different, right? You're spreading the electricity out over a greater real estate, and so it dissipates as it enters the soft tissue, and then it's good for muscles.
Right.
But then you got to like really turn it up in order to hit the nerves. But by that point, it's shocking you and it's uncomfortable. And then the other thing is, as soon as you turn it off, the pain comes back. But this is totally, I mean, it follows some of the same concepts as far as gateway theory and where you're rubbing your arm after it hurts. It follows similar theories to that, but it's much more potent. It's right over the spinal cord. The power is much less. Side effects are almost absent from this type of thing.
So much more precise.
It's
Yeah.
just a far superior. So you really can't compare it. It's like a Flintstones car and a
Yeah,
Lamborghini.
it really is apples and oranges. I mean,
Yeah.
it's I hear it every day because it's the closest way people have to explain, internal TENS unit, but it really is apples and oranges. Yeah.
All right. Well, Wayne, thank you so much for spending time with us today.
Thanks for having me.
Helping us learn a little bit more about your awesome technology. And yeah, hopefully people out there can hear about it, ask questions about it. If any of this sounds interesting to you guys, do leave a comment, like, and subscribe for more. And ask your doctor about a spinal cord stimulator. It may be right for you. Until next time, take care.